Thank you for your patient listening. And I've got some questions in the chat box. So I don't find the name actually. Okay. Doctor, what are the two factors we look for while treating type 2 diabetes patients when multiple OAD failures have occurred? Okay, that's what I told you. The patient is affordable. We can go for. See, the first answer is after the 3 OADs, the patient fails to get back to the normalcy as far as the glycemic triad is concerned, that is the fasting plasma glucose and the postprandial glucose, 2-hour postprandial glucose, and the HbA1c are not met with 3 OADs. It is high time you need to switch over to insulin along with the existing OADs if the patient is not in DKA. If the patient is in DKA, you need to stop all the OADs and you need to go for a complete the treatment algorithm of DKA with the basic 3 principles, the regular insulin and the correction of dehydration and the correction of the electrolyte imbalance. If the patient is not in DKA, along with the existing OADs, you can go for the insulins. The affordability becomes the biggest barrier. I don't endorse that everybody should start prescribing this particular insulin, degludec and aspart. As far as the affordability is concerned and you don't want to have the cumbersome side effects of the conventional biphasic premixed the either human insulins or the analog insulins, you can go for this insulin co-formulation straight away. And the factors we look for is the first one is the efficacy, that it should be able to control all the 3 parameters, that is the fasting plasma glucose and the postprandial plasma glucose and the HbA1c first of all. And the second thing is no weight gain and lesser incidences of hypoglycemia. These are the 3 factors to be kept in mind whenever we switch over to insulin in case the 3 OADs failure to get the patient back to normalcy as far as I have mentioned. Second question, when we have to give insulin, which is the best insulin? Is it IDEC asp or insulin glargine? Yes. See, I have told you there are, according to the American Diabetes Association recommendations, if the A1C is around or more than 9%, it is mandatory that the patient should be on insulin first. And second thing is, the patient is on 3 OADs and not able to get back to normalcy as far as the glycemic triad, it is the mandatory condition that the patient has to be shifted to insulin. And you ask the next question in the same series, the best insulin, you wanted to know whether it is the IDEC asp or the insulin glargine. See, insulin glargine is a basal insulin, whereas insulin, the degludec and aspart is a basal plus insulin, also known as the co-formulation. Actually, this is the only one co-formulation that can take care of the fasting plasma glucose and the 2-hour post glucose and the A1C, because this has got a long-acting basal insulin degludec combined with a rapid-acting analog insulin aspart. Whereas coming to this particular insulin glargine, it is only a basal insulin which can control the fasting plasma glucose and not the postprandial plasma glucose. Hence, the A1C will not be maintained with basal insulin alone. But to tell you the honest answer, there are multiple methodologies to initiate insulin. The first is to start basal insulin along with the existing OADs. Suppose the patient is on 3 OADs, you want to start the patient has got some apprehensions and all. See, as cost wise, I think they both are they almost the cost is not that different when compared to the insulin glargine, the co-formulation insulin degludec and aspart when compared to the efficacy, when compared to the lesser hypoglycemias, when compared to the low weight gain, it has got the so many plus points when compared to the basal insulin alone. So even glargine is also not a cheaper one. This is also the basal analog insulin. So you can start basal insulin with the existing OADs, and if it is not effective, it is not able to control the glycemic triad, it's high time you have to go for the insulin degludec and aspart. See, what I mean to say is, so to have a continuous better control, instead of trying all these things, like straight away it's better you start insulin degludec and aspart. 100% there is no comparison between the basal insulin and the co-formulation. Co-formulation is much superior to the insulin glargine, that to U100. You have not mentioned, but I have to make it very clear. So U300 has come into vogue, the glargine U300. So it is some way comparable to this particular insulin degludec and aspart, but it is not equal or superior to insulin degludec and aspart. Either the strengths, either the glargine 100 or glargine U300 also. And can we use IDAC in type 1 diabetes? Yes, you can definitely use this IDAC in type 1 diabetes. Is IDAC safe in renal and hepatic impairment patients? Absolutely yes. Insulin degludec and aspart are safe in both the renally impaired patient and the hepatic impairment, that is the chronic liver disease. Both the ways it is very efficacious, and you can use it. Only thing is you should reduce the dose as far as the renally compromised patients are there, to avoid hypoglycemia, because any renally compromised patient with low EGFR, they tend to the stagnate the insulin. They cannot send the unused insulin completely throughout the urine. So there is some sort of stocking effect. Actually, the cumulative effect of that insulin may result in unexplained hypoglycemias. So anything should be used in moderation. That is with the low dose you go and keep titrating unless the patient doesn't get into the unexplained hypos. See, is IDAC once daily or BID? To start with, you can start with, if the patient is very is scared of insulin, so you can start this insulin degludec aspart once daily, and that should be started with the largest meal of the day. You should ask the patient whether the breakfast or the lunch or the dinner, which is the largest meal, that contains the largest portions of carbohydrate, and that particular time you can use this insulin. Just 5 minutes prior to the meal you can use this insulin. And most of the times, in my practical experience, my clinical experience, I never had started this insulin degludec aspart to start with once and increment it to the BID doses. I always advise you to go for the BID doses, that is in the morning 8 o'clock, 8:30, just before the breakfast, and the same 12 hours is to be maintained apart to have that effect, and the night also. And the biggest advantage of this insulin degludec aspart is that it is a long acting one, so that even you vary the time also, the efficacy will not change. You will have the same effect. Suppose you take in the morning like 7 o'clock, you take the night 10 o'clock, the insulin degludec and aspart, the effect will not vary and the reductions will be the same. And doctor, which insulin is more cost or high price as we compare with insulin degludec aspart or the insulin glargine? See, to tell you very honestly, the costliest insulin is insulin degludec. As far as insulins are concerned, I don't know the strategy behind this, the pricing and all, because like you, I am also a clinician. See, they have priced it very high. The Novo Nordisk people have priced it so high that insulin degludec costs around the Tresiba 2000 rupees a flex pen, whereas the insulin degludec and aspart 300 units, all analogs which come in the pen form or the use and throw or the cartridge or the pen fill, whatever you say, it is only 300 units. So 300 units of this costs around some 1450. They have slashed down even to the lowest level, but again they have gone high with the prices. And insulin glargine, to the best of my knowledge, it will be somewhere around some 800 to 1000 rupees. So in anyway, when compared to the insulin glargine, whether U100 or 300, the insulin degludec aspart has got an advantage over it has got an edge over the insulin glargine. Doctor, why can't we start directly insulin degludec aspart to patients as initiation instead of insulin glargine? That's what I have been telling. It's a wonderful question actually. See, many a time in my speaker programs I had repeatedly told you, see, as per the theory, that is initiation of insulin starts with the basal insulin. But nowadays, the earlier days, around 30-40 years ago, the funda was different. Treatment of diabetes, type 2 diabetes. Now the latest funda is strike early, strike hard. That is the funda. So instead of going for the basal insulin, trying it for 3 to 6 months or 1 year, the patient doesn't turn up. He keeps using that the insulin glargine, the basal insulin, for years together, and he will not come for visit and all. And after 5 years, he lands up in a complication because of the hyperglycemia. And at that time, we cannot help the patient. So, as you said, it is the best practice to start insulin degludec aspart as the first insulin. The patient has got there are no affordability problems, and the countries where they have got the comprehensive insurance system, like the US, the NIS, or the UK, the NHS, even the most of the Gulf countries, all over the world, you have this the comprehensive insurance system where the patient doesn't need to pay from the pocket, and you take an insurance policy, everything is covered. In that case, straight away go to this insulin degludec and aspart. Even otherwise, a country like India where the patient has to pay from the pocket, I always suggest, if money is not a barrier, to have the beautiful effects of the insulin degludec and aspart, which I have mentioned, the convenience and the mealtime flexibility and the efficacy and the lesser weight gain and the low incidence of hypoglycemia, on top of it the convenience, on top of it the efficacy, which is the most desirable one which we look for, the clinical benefits of insulin. So I always suggest insulin degludec aspart when compared to all other insulins. either the basal insulin glargine 100 or GU 300, or this particular basal bolus, where multiple injections have to be taken, and at least two types, the one basal insulin and the one bolus insulin, and the biphasic premixed human analog human insulins, or the biphasic premixed analog insulins also. This has got edge over that with regards to what all the qualities I have mentioned, the greatest advantages of the co-formulation, that is the combination of insulin, degludec and aspart. I think the questions are over, it seems. If anybody has got any questions, you can unmute yourself.
There is no
option. Yeah. So these people say you don't have an option to unmute yourself and ask the question. So still, if you have any questions and all, feel free to type in the chat box so that I can take up your questions. See, it seems, if I am not wrong, all these questions are asked by Dr. Homayun, who lives in Saudi Arabia. Is an internist. He works for the Department of Internal Medicine. He has not written his name, but I know is my good friend actually. So the doctor who had put all these questions, I'm highly thankful to you. Are you satisfied with the answers, or you want some elaborate answer? You can just put yes or no. That's it. Okay. You want some clarification? You say I need some clarification. You don't want anything. You say yes, satisfied. Please. The last question is a very good question actually. See, which is why can't we start directly the IDACASP? You have to start with IDACASP only, that is twice daily. Please always make it a point. Don't waste your time even starting with the largest meal, again not getting controlled, again making it twice. Day one itself you make it twice a day. That's it. I don't find any questions actually. So if there are no questions, I think check once. If there are no questions, we'll wind up this session. Okay.
almost all 9 questions posted by the audience, all the audience. Doctor has given wonderful answers for this. I'm requesting now we'll wait for another 1 or 2 minutes here for your any clarification you need. You require any more elaborate answers here.